Ma'am, you make me
Dr.
also.
Shamik, let us start, please. Dr. Shamik,
Yes, ma'am. I'll just wait for Dr. Nirmala to
start
Yes.
the program.
Yes, madam, it's working. Thank you, ma'am.
Should I stop sharing?
Yes, ma'am.
Yes.
Sir, can you make me also?
Hi, Nirmala.
Good evening. Good evening.
Good evening.
A very good evening to all of you, and immense gratitude to the Non-Communicable Diseases chapter for having joined hands with the Adolescent Health Academy in this particular endeavor of ours to deliver holistic and complete care to our adolescents in different spheres. Today, we'll be touching upon a few non-communicable issues in the adolescents. And I now hand you over to our MOCs for the evening, Dr. Swati Ghate and Dr. Deepa Janardhan, to take the proceedings.
Thank you, sir. I request Sushma madam to give give a little bit of an address on this occasion.
Ma'am, you're muted.
Very much thrilled to see all the doyens of NCD chapters and AHA chapter. And I welcome from bottom of my heart to all of you. I will not take much time, but it's a sheer pleasure and honor of Adolescent Health Academy to have you all on board today with us. Dr. Suchit ji, Dr. Nirmala ji, Dr. Jugesh madam, Dr. Ranju madam, Dr. Chitra ji, and Dr. Smita ji, and all the speakers. I welcome the AHNs, Dr. Hima ji, and the Honorable Secretary, Dr. Shamik ji, Dr. Deepa, Dr. Swati, and all the dignitaries who are there. So let us start the discussion, the scientific deliberation. Thank you so much once again. Swati?
I now request Deepa to introduce Nirmala madam.
Your
Deepa, your voice is not there. Dr. Deepa, your voice is not coming. If you are with earphone, remove the earphone or they change your microphone.
नहीं आ रहा है, आवाज नहीं आ रही है. Can you display the slide?
Dr. Swati, can you take over?
Yes.
Yeah, just continue.
Right. So it is a great pleasure to introduce Dr. Nirmala madam. She is professor and head Pediatrics Department, Government Medical College.
Ma'am, I'm there.
Okay, sorry. Please take over.
Yeah, sorry for the interruption. It's my distinct pleasure to transition us into the scientific proceedings. We have an incredibly insightful session ahead, and I'm honored to introduce our keynote speaker, Dr. Nirmala Chekuri. Madam is the professor and HOD, Government Medical College, Bangkir, Yadadri, Telangana State. She is currently the chairperson of NCDPA chapter of IAP. Last year, she was the chairperson of MEC chapter. She has 25 publications in index journals. She has been the faculty at local, state, and various national pediatric conferences. Nirmala Madam's contributions to non-communicable disease prevention have been foundational, and we are privileged to have her expertise shared with us today. Madam, the floor is yours. We have scheduled 20 minutes for this presentation. I'll provide a brief, gentle reminder at the 17-minute mark and a final nudge at 19 minutes to ensure we keep our session on schedule. Please go ahead, ma'am.
Okay, I'm sharing my screen. Yeah. So you'll be checking the time now. So it is 8:35.
Yeah.
Right?
Yes, ma'am.
So, yeah. Just for confirmation. Good evening, all. At the outset, I would like to thank the chairperson, Adolescent Health Academy, Dr. Sushma Desai ji, and Secretary Dr. Shamik Ghosh ji for the initiative of Interchapter webinar and starting with the NCDPA and AHA. And thank you very much. At the outset, my topic is on lifestyle, environment, and early metabolic risk. How preventing adult non-communicable diseases begins in adolescence. So the outline of my presentation will be to understand the global burden and the adolescent origins and the Dohad hypothesis, and what about the insulin resistance and the various behavioral and dietary patterns and effect of sleep hygiene and environmental toxicants on the endocrine disruptions, and what are the preventive strategies. So what we understand by looking at NCDs, the most important thing is the non-communicable diseases account for 75% of the global deaths from NCDs and about 71% of the premature deaths, and mostly occurring in low and middle income countries. And the risk factor exposure begins in childhood and adolescence. And if you look at 1.4 billion overweight and obese adults are there globally, and 70% of the adult type 2 diabetes mellitus risk factors start in adolescence. And if you see economically, the cost of inaction will lead to 47% $47 trillion projected cost, right from 2011 to way back to 2030. So the WHO Global Action Plan targets about 30% reduction by 2030. So if you see 7 in every 10 deaths worldwide often are from avoidable causes, and you see the percent of total deaths attributable to these NCDs in all ages, particularly in the South Asia and Saharan Africa from 2008 and to 2030, which is the future vision is from 51% to 72%, whereas in Sub-Saharan Africa, it is from 28 to rising by to 46%. So it is very important that we need to identify the risk factors and take up the preventive strategies for the future generations. The non-communicable diseases, as we understand, are lifestyle diseases which are chronic and non-infectious and will have a greater impact on the adult outcome of NCDs, which will lead to premature deaths. The life course approach for the prevention of NCDs, if you look at it, the developmental origins of health and disease, it indicates that the environmental conditions during the fetal and early postnatal development influence the lifelong health and capacity through permanent effects on growth, structure, and metabolism. So the mother's diet is very important, wherein the ability to mobilize, transport nutrients, at the same time the nutrient stores and supply line to the fetus. If at any point of time there is and mother through placental supply is unable to supply the nutrients to satisfy the fetal demand, there can be a fetal undernutrition, leading to inadequate building blocks and adaptation to reduce demand, wherein there is HPA access and increased cortisol levels, leading to early maturation. And these all effects on the other organ systems may lead to central obesity and other features like adipose tissue differentiation and adipokine set points, and changes in the gut microbiome colonizations, and leading to fetal and early postnatal nutrition effects with determining the metabolic phenotype. And the sensitive periods are are periconceptional and the first 1,000 days, and during the adolescent period is taken as an early developmental window period where you have the opportunity to do the prevention of adult outcomes of the metabolic syndrome. So why adolescence? The adolescent development and the determinants of health is very important, because at the individual level, as well as at the interpersonal level and at the institutional or the community level. When you're talking about the individual level, the puberty, the brain growth takes place, and also the there is cognition, evolving cognition abilities, which will lead to the risk taking up personality or the character, and risk-taking behavior, I would say. And in the changing interpersonal relationships from the family relationships to the peer relationships will have an effect on their behavior pattern. And the school, at the community level and institutional level, if you look at that, the important is the school environment as well as the society environment and the local environment, which will help in the adolescent health or adolescent well-being and making them thrive well. Why adolescence matters is because of the changes, the biological changes that take place with not only the linear growth, but the hormonal changes and also the psychosocial emotional factors that because of the changing hormonal milieu, there will be behavioral shifts wherein there will be dietary autonomy and influence by the peers. And there can be a sedentary behavior with increasing screen time and changes in the sleep, that is the sleep hygiene, the sleep phase delay, and which will lead to circadian disruption. And there would be emotional outbursts as well as the stress with regards to the school and other peer stress. And also there can be initiation to tobacco and alcohol use. So leading to metabolic consequences of... Yes. Sir, can you please mute? Leading to metabolic consequences of impaired fasting glucose and dyslipidemia, and also increase in the inflammatory cytokines. So how do we track the metabolic implications of, if you see the adolescent age group and the dietary patterns, we usually monitor the anthropometry in under 5 years as per the growth charts, WHO growth charts, and beyond that we try to do the BMI tracking from childhood to adulthood. So whenever there is an increase, the body mass index is increasing, then it reflects to the with 80% consistency into adulthood. And also when you monitor the waist to height ratio, it is more predictive of cardiometabolic risk than BMI alone. So the adiposity and the disease pathway is very important to understand that increase in the visceral fat, there will be a release of free fatty acids and insulin resistance, wherein there can be hyperinsulinemia, but the response to this is resistant in the cell. So there can be a B cell exhaustion and type 2 diabetes. So there is something called as TOFI phenotype, wherein there may be thin outside and fat inside. So 30% of normal weight teens can still have metabolic dysfunction, because when you look at it, there will be increase, though the weight is normal, when there is a normal weight and normal BMI, they will have lower risk. But when there is increased weight circumference, despite the normal BMI, that is, they are looking thin outside, but there is fat inside, they will have an increased risk for metabolic disease. So what insulin resistance during adolescence, is it physiological or pathological? We need to understand this. So in the physiological, during the puberty, there will be a transient growth hormone mediated physiological insulin resistance, which usually normalizes by late puberty, and this facilitates usually the linear growth. Whereas in pathological insulin, this persists beyond puberty and it worsens with obesity, and usually it will be associated with the metabolic syndrome. So, and dyslipidemia, which is often associated with this increased cardiovascular risk, and you look at the LDL and the HDL, which is the HDL should be more than 45 as it is a protective cardioprotective factor, and LDC in the in adolescence tracks into the adulthood. So the recommendation is for universal lipid screening at 9 to 11 years and 17 to 21 years. So when the healthy vessels look normally with a normal endothelium and there is the lumen is normal, whenever there is high shear stress and lipidic abnormalities, there will be endothelial dysfunction and increased vascular resistance, leading to the atherosclerotic plaque and the cardiovascular diseases and the risk for stroke. So what do we understand by metabolic syndrome in adolescence? The diagnostic criteria and prevalence is whenever there is central obesity with the waist circumference of more than 90th percentile, which is age and sex specific, plus any of the two changes in the biochemically, either increased triglycerides, which we define as more than 150 milligram per deciliter, or on specific treatment, and increasing fasting glucose of more than 100 milligrams per deciliter, or increased blood pressure, or decreased HDL to less than 40 in males milligram per deciliter, or less than 50 milligram per deciliter in females. So the global metabolic syndrome prevalence in adolescents in general will be in the general population 3.3% risk may be there, but it increases to 30 to 50% in the obese individuals. What are the dietary patterns which are of impact? They are basically high glycemic load diet and increase the postprandial glucose with the increased insulin, causing stress on the beta cells. And also these foods are basically are associated with decreased fiber and vitamins and mineral salts, but they're because of the increased palatability and also they have increased caloric intake and fat and less of fiber. So this will have an impact on the even the gut microbiome and increased BMI, waist circumference, leading to hypertension, dyslipidemias, and also increase in the inflammatory kinins, and that is low-grade inflammation starts and insulin resistance, and these become the cardiometabolic risk factors. The physical inactivity and sedentary behavior has been effect on the metabolic markers, wherein the effect of exercise on metabolic sedentary time more than 3 hours a day increases the triglyceride levels and decreases the HDL and increased adiposity. And screen time more than 2 hours per day independently raises the systolic blood pressure in the children. By doing effect of exercise is it reduces the triglycerides by 10 to 15% and blood pressure by decreases by 3 to 5 millimeters of mercury. So impact of physical activity definitely improves the insulin sensitivity as well as decrease in the peripheral resistance, thereby its effect on the reduction on the blood pressure. What about the screen time and digital behavior and metabolic risk? The digital environment and average screen time for adolescent is 7 to 9 hours per day, as we have seen in media studies. The screen time impacts the sleep quality of the sleep and reduce physical activity with a circadian disruption and insulin resistance. And it also increases the levels of anxiety and depression. So gaming and binge watching also leads to mindless snacking and appetite dysregulation. And guidelines have WHO and AAP, American Academy of Pediatric guidelines show that less than 2 hours recreational screen time for 5 to 17-year-olds. The chronobiology of metabolic disease with respect to the sleep deprivation and circadian disruption is the circadian misalignment leads to increased cortisol and increased postprandial glucose. And also social jet lag more than 2 hours per weekend or weekday mismatch increases the risk of metabolic syndrome in the teens. So decreased sleep, increased cortisol, increased ghrelin, which is the hunger hormone, leads to increased appetite and obesity. So why does your teen have trouble sleeping? If you take as per the national poll on children's health in 2018, won't get off electronics. 56% said they're not able to get off the electronics, and irregular sleep schedules due to either homework or activities seen in 43% of the teens, and the 31% are worried about the school and 23% about their social life. So the stress and metabolic disease pathway, the adverse childhood events, if there are more than or equal to 4 adverse childhood events, there is an increased twofold risk of type 2 diabetes mellitus in adulthood, because chronic stress activates the HPA axis and sustained cortisol elevation, and also leads to depression in adolescents, which is 37% higher incidence of metabolic syndrome in a 10-year follow-up. So some of the environmental toxicants and endocrine disruptions, if you see, these will have an effect on the hormones. These are particularly the phthalates, also the organic pollutants, the heavy metals, air pollution, and microplastics, which have an effect. And also PCOS is one of the examples for these endocrine disruptors. So the gut microbiome and metabolic health, if you see, whenever there is increased ultra-processed foods, and also the delivery peaks in diversity, the gut microbiome diversity peaks in adolescents, a critical programming window. So whenever there is a change in the gut microbiome, there is trimethylamine which increases and then gets metabolized in the liver, leading to trimethylamine oxidase, which has an effect on the metabolic cardiometabolic risk and metabolic disorders. So the hormonal milieu during adolescence, the precocious puberty prevalence is rising, possible link to obesogenic diet and endocrine disrupting chemicals. So this we have seen as which affects about 8 to 13% of the adolescent girls and having an insulin resistance. So, and also the adolescent hypertension. So prevalence of hypertension is to the extent of 4% and pre-hypertension seen in 10% of teens. And the childhood BP tracks to adult hypertension, and masked hypertension has to be picked up by in the normal, wherein the blood pressure will be normal in the clinic but elevated in the ambulatory readings in 30% of the teens. So the epigenetics and transgenerational programming is important because window of epigenetic reversibility can happen during adolescence. So which is a key intervention target. So not during this is the critical window period as well as the fetal and early infancy and the adolescence. So the screening and biomarkers are who, when, and what is. We need to annually monitor the BMI percentiles as well as the waist circumference, the blood pressure annually from more than 3 years of age group, and also the fasting glucose levels and HbA1c whenever BMI is more than 85th percentile. So also the fasting lipid profile, 9 to 11 years universal and
3 more minutes.
Yes. So beyond the conventional screening, we have the other emerging novel biomarkers like leptin adiponectin ratio, as well as the highly sensitive CRP levels. And what are the prevention strategies that we have? That is, one is dietary modification interventions, wherein Mediterranean diet, the intermittent fasting which has come into existence, and the DASH diet to stop hypertension, that is dietary approaches, and also the reduce the ultra-processed foods and sugars, sweetened beverages, and low glycemic diet, and increase the dietary fiber, and mindful and structured eating is very important, which improves the weight maintenance as seen in the randomized control trials. So this is the functional bioactive foods which need to be taken into consideration, which leads to a healthier metabolic state. And future directions are personalized nutrition and nutrigenomics, where the microbiome research is going on. So aerobic exercises more than 60 minutes a day reduce the visceral fat and improve the insulin sensitivity. And also the high intensity interval training, 12 weeks, they reduce the waist circumference by 3.7 centimeters. And also school-based physical activity programs are most cost-effective interventions. So the adolescent mental health and physical fitness key benefits are a mood enhancement, improved sleep, cognitive boost, wherein improves the concentration and memory, and social connections, builds supportive in relationships. So multi-level approaches is at the school levels, where healthy school meals and daily physical activity and health education, no sugary drink vending machines, and mental health counselors in the campus. And family level, family-based behavioral therapy and motivational intervene. Yes, one more slide. And at the community level. So assess, advise, agree, assist, and arrange is the structured approach to the adolescent metabolic health. Why? And reversibility of early vascular aging happens with the lifestyle interventions, with normalization of blood pressure and metabolic improvement, which has long-term benefits of prevention of adult cardiovascular disease. Why do we invest in adolescent well-being is because it gives a triple dividend, not only for adolescents, their future adult lives, and for the next generation, and also have an economic benefits. So to summarize the key messages, adolescence is the last best window to interrupt the NCD trajectories. Metabolic risk tracks, visceral fat, blood pressure, lipids, and insulin resistance set in adolescence persist to adulthood. So prevention is very important through lifestyle modifications And pediatricians must screen early and act proactively and advocate for the systemic change in addition to the policy changes and improve the environment for space for children's activities. Thank you.
Thank you very much, Nirmala Madam, for such a comprehensive and a practically very useful lecture on such a vast topic. And you have covered so many points so nicely. And there are so many take-home messages which we can directly start implementing in our day-to-day practice. It was a very enlightening lecture. And if there are any questions, we will take them at the end. Thank
Okay.
you very much, ma'am.
Thank you.
Now moving on to our second part of the program, that is the panel discussion, which is a case-based discussion that will be moderated by our Dr. Suchit Tamboli sir. Sir, may I share screen to display the CV slides? Can you see my slides?
Yes, they are visible.
Go ahead, Dr.
Yes.
Swati. Yeah.
Yes, thank you. So I'm very happy to introduce Dr. Suchit Tamboli sir. Welcome, sir. Sir is a very well-known pediatrician and a very distinguished pediatrician. He is the first first doctor to be honored PhD from Maharashtra University of Health Sciences. That is a very distinguished honor, sir. And he has many other awards to his credit. So he is a very, very passionate worker in the field of developmental pediatrics and adolescent pediatrics, and has been a writer and a guiding force to so many pediatricians and to children. In Maharashtra, especially, he is conducting so many courses, including the career counseling courses, and which are very, very helpful for the young generation. He was chairperson in the Government of Maharashtra's Disability Certification Committee and has a wide experience in disability management. He was an organizing committee member of World Pediatric Congress held at Singapore, and he runs his YouTube channel, and he has more than dozens of videos for children and parents to learn about various aspects of child health. Sir, welcome to this forum, and we are lucky to have you as our moderator for the panel. Coming to our panelist, first panelist, Professor Jugesh Chatwal, madam. Madam is very well known in the field of NCDs and obesity, and she has several papers to her credit, and she is also a very important co-author of obesity guidelines of Indian Academy of Pediatrics. I have been fortunate to work with her, and her other interests are asthma, infectious diseases, and medical education. She has also authored many chapters, and very proud to know that madam has also contributed in Hutchison's Pediatrics. That is a great honor, madam, and we are proud of you. She is also associated with FAIMER, which is a federation which works for medical education and research. Madam, welcome. We are honored to have you. Our next panelist is Dr. Smita Mishra, madam. She is HOD in Department of Pediatric Cardiology, Manipal Hospital, Delhi. Madam is very passionate, and she is always there for the needy children, and she has been appointed as a trustee in Kailash Satyarthi Children Foundation. That is a very prestigious position, madam. We congratulate you for that. She has been on various important crucial positions in IAP and Women's Wing, and has been a very important contributor to disability criteria for cardiac patients, and she has authored a paper on that. Madam is also very well known for her heart-touching poems. Madam, you are welcome to the panel.
Thank you. Thank you so much, Dr. Swag.
Next panelist is Dr. Anju Veeramani. Madam is a very renowned pediatric endocrinologist working with Max Super Speciality Hospital, New Delhi. She is trained in AIMS, and that speaks volumes. Madam is very passionate, and she was the first person to start cord blood TSH screening in several hospitals of Delhi. She set up first diabetic of young clinic way back in 1988, and she has organized series of diabetic camps across North India. She is the lead author of guidelines on diabetes care in limited resource setting, and also a program director of IDL, and as ISPAD award-winning online course on pediatric diabetes educators, and she is also editors of various newsletters in the endocrine chapter. Madam, you are most welcome. We are eager to learn from you. Our last panelist is Dr. Chitra Dinakar from Bengaluru. Madam was formerly professor and head at St. John's Medical College and St. Martha's Hospital, Bengaluru. Now she is into private practice. She is an ardent adolescent pediatrician and a very active member of AHA. She has several papers to her credit, and her other interests are chronic infections and community pediatrics, NCDs, and treatment of vulnerable children. That is the galaxy of panelists that we have today, and we are eager to learn from you. I hand over the stage to Suchit sir for further proceedings. The time for this panel is 1 hour.
Yeah. Thank you very much, Swati madam, for nice introduction of all faculties. And I think we will start this panel discussion on adolescent lifestyle and metabolic disorders. So our opening batsman is Dr. Jugesh madam, and I ask her to start her place history. And after 10 minutes, I will just give the warning. Thank you.
Thank you very much. Thank you, Dr. Sushma Desai, for starting this program. And thank you, my own parent, NCD chapter, for getting involved with the AHA. And it's a very, I think, very useful and a very worthwhile activity that we are doing, knitting the two chapters together. So going straight to the case history is about a 14-year-old adolescent boy who was brought by parents with the complaint of excessive weight gain, which happens to be a frequent thing that is happening nowadays in our outpatient departments. This boy is studying in class 9 and has poor school performance. He sleeps daily at about 1 to 2 a.m., wakes up at 7 a.m. and has daytime sleepiness and snoring also when he's sleeping. Physical activity is minimal. Family history, father has got a type 2 diabetes mellitus and mother is obese. The dietary pattern is that he's taking snacks 2 to 3 times per day, almost daily consumption of aerated drinks. Daily he has ordered in meals, and there is minimal home cooked foods and fruits that he has consumed. A quick heads assessment for him. Both parents are working and meals are often ordered or rushed. There are very limited family activities, and he's alone at home after school till evening when he's ordering in all the foods, and also accompanied by cold drinks. He has below average performance and he complains of tiredness in class, has aggressive behavior at times and fights with his younger sister. Activities wise, he spends nearly 8 to 10 hours on mobile gaming and social media after school, and there is no outdoor play, no outdoor play even in the schools. Drug substances, he denies use, but he consumes sugary drinks and energy beverages sometimes. There are no romantic activity, but he's teased by peers about his weight. He's obese, so he's teased. And he does not have any suicidal thoughts, but has low self-esteem and definitely has body image issues. Safety-wise, there are no major concerns that were there in the heads assessment. Next, yeah. So a physical examination showed that he weighs 92 kgs and his height is 164 centimeters with a BMI of 34.2 kg per meter square, which is above the 97th centile. Waist circumference is also high. Blood pressure, which was an average of 3 readings in the clinic itself on the left arm, is 128 to 84 millimeters. He has acanthosis nigricans, and systemic examination by and large is normal except for a mild hepatomegaly. His preliminary investigations revealed that his fasting blood sugar is 112 milligram per deciliter with an HbA1c of 6%. His lipid profile is deranged. His fasting insulin was elevated, which was done, but it was elevated, and liver enzymes are mildly elevated. The polysomnography shows moderate obstructive sleep apnea. So when we looked at all of these things, he fits into being called a metabolic syndrome as he meets the criteria of having 3 or more features, which are abdominal obesity, which he has with high waist circumference. He has impaired fasting glucose. There is dyslipidemia. He also has hypertension, and there is also obstructive sleep apnea. So he qualifies for being labeled as metabolic syndrome.
So, madam, what are the key contributing factors in this adolescent's metabolic dysfunction?
So metabolic dysfunction in everybody, especially in adolescents, there is a lot of play of factors which is there, starting from diet, physical activity, lifestyles together, diet, physical activity, lifestyle, the screen times, all of them together, the sleep issues, the family history, the OSA also contributes. So they are all interrelated and they together contribute to metabolic syndrome. If we look at the key factors, then excessive screen time, sedentary lifestyle, which go hand in hand. And this also influences the sleep hygiene and sleep deprivation. There is unhealthy eating pattern in this child. He has a family history of metabolic disease, and there is reduced physical activity. His circadian rhythm is disrupted. He is having late sleep, waking up after poor sleep, and that worsens the insulin resistance. He also has obstructive sleep apnea, which contributes to fatigue and weight gain. So altogether, all of these factors are contributing to his metabolic dysfunction.
So, madam, how does screen addiction worsen obesity and prediabetes?
Yes, screen addiction does have a significant contribution to it because the more time the adolescent spends in front of the screen, the more dangerous it becomes because it is always accompanied by reduced calorie expenditure and increased eating. There is unmindful eating. He doesn't know what he's eating. He's just ordering in and putting food into his mouth. He doesn't know what is going in. He doesn't know when he is full and he's overeating. There is stress eating. Increased snacking and sugary beverage intakes is also there. It delays the sleep onset. There is a dopamine-driven compulsive behavior associated with screen addiction and hormonal dysregulation also there, which involves the leptin and ghrelin, the 2 hormones controlling the appetite, poor academic and psychosocial functioning. So altogether, this contributes to the metabolic dysfunction.
So, what should be the management plan?
The management plan, when the problems are at such multiple levels, it will be a multidisciplinary management. But first and foremost, when such a adolescent is there in the clinic, the first and foremost step before we really go into the nitty-gritty of the treatment of the child is the education and counseling of the family. We mustn't miss out on this part, that is education and counseling of the family, because that is going to be the most important platform on which the treatment will work. So one must employ motivational interviewing here, use a positive and a non-judgmental approach and not put labels on the child. Parents also are to be advised to not do that. We have to emphasize that management is for the long-term health of the child. It is not just for the immediate correction of the weight. And involvement of the family in the lifestyle modification is very important because without shaming, the family must be part and parcel of the treatment. And we need to explain the risks of the metabolic syndrome this child is having, which can lead to type 2 diabetes and heart conditions. So in the dietary modification, without going into too much detail, we definitely need to have a dietitian on board who can advise them on a low glycemic index and high fiber diet plan, also a DASH diet, because his blood pressure is elevated, and it will be a good idea to give them a weekly diet plan. Cut the sugary beverages, preferably zero, but at least decrease them definitely. encourage structured meals and mindful eating, and avoid emotional eating. Avoid eating in front of the screen. This is very vital. And eat together as a family, at least to begin with, 3 times in a week. That can give them a family belonging feeling, and also the eating would be more controlled. In the physical activity, we can, to begin with, ask him to start having a brisk walk of 30 to 45 minutes duration, which can be gradually built up to 60 minutes per day, and later on move to strength training or yoga 2 to 3 times per week, and encourage the adolescent to join an organized physical activity. He can join a gym or a sports activity if he's interested, or even a dance club or something where he can learn dancing. Track his progress via step counter or a physical activity diary. That is also important. The sleep and screen needs to be addressed. So we need to advise them about maintaining sleep hygiene, reducing the screen time to less than 2 hours, and treatment of obstructive sleep apnea may be warranted in this child since he has a moderate obstructive sleep apnea. Psychosocial support is very essential. We need to address the body image issues and his mood fluctuations. We can encourage the adolescent to maintain a journal where he can talk about the feelings he has about his negative body image, which is affecting his daily functioning. It can also be an outlet for him to express his feelings. We discuss stress management techniques with the child, mindfulness and adolescent support groups if he can join, and screen for any clinical anxiety, depression if one feels on assessment that there is a need for it. We do not stop only at advising all of this. It is very important to have a monitoring plan. Otherwise, we are doomed for a failure. So we need to have a monitoring plan where the weight, the physical parameters are to be monitored, and the rest of the things also. So the weight, blood pressure, and the BMI, they must be monitored every visit monthly for first 3 months at least. Then we can decrease the frequency maybe a little bit. Fasting glucose lipids only to be done after 6 months. Mood, sleep, and physical activity at every counseling session. We need to inquire how it is going, whether it is coming into the normalization phase or not. Anticipatory guidance regarding the management is important. This is regarding the management, not anticipatory guidance as a prevention, but as a part of the treatment here. So the elements to be looked at are adherence to lifestyle changes is essential. That is mainly the dietary modification and physical activity. And we have to inform the family that the results are not going to be apparent in a short time. Do not expect a weight loss in the next 2 weeks or even a month. It will take some time, and consistency is the key. And only over 6 to 12 months, the effects will be visible. So they have to be patient and stick with the plans. Family support is very vital, especially for diet and physical activity. If the child is not eating high-fat food and everybody else is eating, it's going to be a sad family for the child. So they need to be involved in the management of the child. Involve the school to support non-judgmental participation in physical exercise if possible, and absolutely emphasize the sleep hygiene and screen time boundaries. Next.
Yeah. So we have finished 10 minutes.
What are the anticipated outcomes? We expect a weight reduction of 5 to 10% over 6 to 12 months, and a normalizing of fasting glucose, triglyceride, and HDL within 6 months, and improved confidence over a period of time. Next.
So when should pharmacotherapy or bariatric referral should be considered?
Okay, so this is not something that you would definitely consider at the first visit. One needs to first assess the situation for the adolescent. And intensive lifestyle-based management must be instituted beforehand. Before we embark on pharmacotherapy or surgery, we must have the lifestyle-based management in place, because the pharmacotherapy and surgery are not going to give a miracle response to this. This has to be accompanied by lifestyle-based management. And we can consider these only when the child has a BMI which is 35 or more with comorbidities, or if it is, can I see the previous slide? Yeah. Or if it is more than 40 without comorbidities. But again, very important that one must counsel the family in adolescent before we consider pharmacotherapy and surgery. Next. So this is a very brief stage management plan for different levels of obesity, but practically for every level of obesity, the first step would be the stage 1, which is prevention plus. And we start with the 5-2-1-0 for the diet, weight, and sleep pattern and the screen time. And the response should be visible in the 6 months by sticking to 5-2-1-0. If we do not find any response to this, if the weight does not stabilize, leave alone weight reduction. If it doesn't stabilize, then we can move on to stage 2, which is structured weight management, in which we have to advise structured daily meals, healthy snacks, definitely reduce screen time and physical activity. Again, we are basically on 5-2-1-0, but a more stricter implementation of the 5-2-1-0 plan. And the response should be visible again within 6 months. Here, we would look for some amount of weight loss as well, depending upon the age of the child. In the younger adolescent, we may not, but in an older adolescent, we would look for a weight loss. Stage 3 is if the patient does not respond to, if there is no response to stage 2 for 6 months, then we move on to stage 3, which is the comprehensive multidisciplinary intervention, where structured behavioral modification program is done, and it is a short-term diet plan, which may be an extreme calorie reduction also, with again structured physical activity, again tried for at least 8 to 12 weeks, expected to have a weight loss over here. And if there is no response to this, then we have to have a tertiary care intervention, which is the stage 4, where the patient may need to be hospitalized if they have significant comorbidities also. And then we continued with diet and physical activity and consider other options in that situation, medications or bariatric surgery if required.
So now it was excellent presentation by Madam. So I just want to comment that adolescent obesity today is no longer simply a nutritional issue. It is strongly linked with the digital behavior, sleep disruption, and mental health. So early intervention must target the entire family environment rather than only the child. And sleep assessment and screen use counseling should become a routine component of obesity clinic. So thank you very much, madam, for your very excellent presentation. Now we will move for the case 2. Dr. Smita Mishra, I request you to start your presentation.
Thank you so much, Dr. Tamboli and the NCDPA and AHA for giving me this particular opportunity. And at the same time, I would request audience that remember all the points discussed before, because lifestyle management has been done very nicely by Dr. Jugesh and before that Dr. Nirmala. So please carry forward that. I am not going to making a detailed detailing on those part lifestyle management, because it has been done already very nicely. So here is a case history of 9-year-old non-syndromic, seemingly chubby original girl, originally from Chhattisgarh, now resident of Delhi, with no previous history of hospitalization. Presented in emergency, there was a history of dizziness, confusion, chest pain, blurring, vision, headache. Pulses were bounding, femoral pulses felt, they were normal, are equal, no radiofemoral delay was noticed, the heart rate was 100 per minute and regular, no murmur or bruit was heard over the chest, back, or renal area. So blood pressure was 178 by 118 mmHg, 190 systolic, both in the both lower limb, and it was a stage 2 elevation of the hypertension. So urine output was normal. There was no edema, no exomphalos, pupil normally reacting, normal skin, no pigmentation, no moon phases. So clinically there was no features suggestive of anything. Then except that obesity. So because child was chubby. So there was a family history which was very important. Mother expired at the age of 23 during delivery of baby, and there was malignant hypertension. Sibling was unaffected. So history of drug intake was this history was taken in detail because at this particular age, 9, 10, 11, sometimes children are prone to have certain kind of medication. So these are the amphetamine, cocaine, dendrite, tobacco, cannabis, and no history was found. Next slide, please. So we can see that height was 135, weight was 40, and if we calculate BMI, it was 21.9, and which was in the range of obesity. Next, and waist circumference was 80 centimeter. So, like we just heard about the metabolic syndrome. So here we can see the waist circumference was high and there was hypertension. The rest of thing was still to be investigated. So next, then another question was, is it a hypertensive urgency or hypertensive emergency? To differentiate both, there is a clear-cut picture of the vital organ dysfunction in the hypertensive emergency. So in this case, it was not there. We labeled it as a case of hypertensive urgency, acute elevation of blood pressure, and there were features, symptoms suggestive of some central nervous system like the headache, blurring of vision, but not exactly the loss of sensorium or something like that, or major event. So next slide, please. It was hypertensive and urgency, and management strategy was adopted according to existing guidelines. So first 8 hours in such a situation, we have to have a gradual controlled reduction of blood pressure, no more than 25%, using oral or intravenous medication. I'm sorry for the mistake. Over 24 to 40 hours, we can attempt to normalize the blood pressure completely, and goal is to prevent ischemic complication of the vital organs or damage to vital organs. So what drug we can choose at this particular moment are the labetalol, captopril, nifedipine, nicardipine, clonidine, and SNP. So in this particular case, nifedipine was used, which is a good drug, and it is administered sublingually, and most of the time in children it works well. So supportive therapy was managing fluid electrolytes, nutrition, input-output measurements, and maintenance was done with the nifedipine extended release tablets. Next. So exactly what it was it a metabolic syndrome related or essential hypertension related to obesity? So we needed to know our lab reports. Here we can see, I have summarized in this separately, that there was high sodium and the bicarbonate, there was hypokalemia, and renin level were later measured and they were low, and aldosterone was low. So was there any end organ effect? Yes, there was left ventricular hypertrophy, but the EF, ejection fraction, was maintained, and the fundus had early retinopathy related to this hypertension. So this was the picture. So coming to differential diagnosis, as we said, that the apparent clinical phases are very important, like they having a proptosis, which may suggest the thyrotoxicosis, abdominal opacity, hirsutism, as we have seen in the previous case, will suggest the metabolic syndrome or the Cushing syndrome also. And then because there will be a moon phase in the Cushing syndrome, then as most important is always look for the femora. In this particular case, there was normal femorals and the normal radiofemoral no radiofemoral delay. So it was no coarctation of aorta. So the another set of diseases to be ruled out were the renal parenchymal disease, the catecholamine based disease like pheochromocytoma, and the renal vascular hypertension. So those were ruled out because plasma renin activity, as we know, was low, and the hypokalemia was there, high sodium and bicarb. So this is a very interesting case of Liddle syndrome. And subsequently, this diagnosis was confirmed on the genetic screening, and it was positive for SCNN1B. It is a uh, uh, autosomal dominant disorder. So just a slide before. Sir. So we have ruled out all these conditions which we needed to: thyrotoxicosis, Cushing syndrome, coarctation, hyperaldosteronism, pheochromocytoma, renal parenchymal disease, and renal vascular hypertension. Next. So Liddle syndrome is an autosomal dominant disorder, monogenic, and characterized by what we have learned just before. It is a salt-sensitive condition. Treatment includes sodium-restricted diet and epithelial sodium channel blockers such as the amiloride and the trimetrin, and the potassium supplementation. We can use additional drug if the blood pressure is not being controlled. Pediatric systemic hypertension, how to manage. Next slide, please. So one thing is very important before labeling a hypertension, we must know there should not be a technical error. So we must know what should be the width of the cuff, the arm circumference midway between the acromion and olecranon. The inflatable bladder length must be 80 to 100% of arm circumference. Width of inflatable bladder must be at least 40% of arm circumference. Any posture, position, pain, tobacco, alcohol, meal, noise, speech, emotions, respiration, bladder distension, age, type of instrument, diurnal variation, all these may lead to abnormal blood pressure reading, and we must always go for 2 or 3 readings before labeling a person as a case of hypertension. But obviously in this particular case, we know that it was actually stage 2 hypertension. This is a updated definition of blood pressure categories, and we know that normal blood pressure is less than 90th percentile, and in general, normal blood pressure is less than 120 by 80 if a child is more than 13 years. Then it may be elevated blood pressure or a stage 1 hypertension or stage 2 hypertension. Elevated blood pressure when it is a more than 90th percentile, less than 95th percentile. The stage 1 when it is more than 95th percentile or less than 95th percentile and plus 12 mmHg are between the 130 and 139 systolic BP, and the diastolic 80 to 89. And stage 2 is more than 95th percentile or plus 12 mmHg, or we can get can take a cutoff of 140 by 90 mmHg. I think we should remember these values for the around 10 years of age children. Okay,
Madam,
next.
10 minutes are over.
Okay,
Two
so
minutes.
1 minute, because why this happens is because of the increased sodium retention from the kidney or vasculopathy, like vasomotor response, some genetic factor, prenatal factors, sympathetic system, and altered vehicle activity. Next. So the 5 step of approach to hypertension is confirmed. We have just discussed all of them. Only important point is ABPM, because we should use the ambulatory blood pressure monitoring, which is very important to record how diurnal variation and all those things. So we must next please.
Hello.
Next.
Yeah.
So then core intervention is DASH style diet, reduce the excessive sodium intake, encourage the moderate to vigorous. These all things we have learned in previous lecture. Only thing is we have to decrease the sodium, and there is a strict criteria given by WHO, and we should actually see how much sodium we are giving to children. Next. And most important is the use of the potassium salt, potassium chloride. This is not easy to use. It cannot be used as such only potassium chloride. So we have to take care of that because it may cause hyperkalemia also. So there are pros and cons of using it. What are the pharmacotherapy? When there is lifestyle measurement symptomatic, if child is symptomatic and organ damage is there, then we can use ACE inhibitor or angiotensin receptor blockers, long-acting CCB, ACE inhibitor and ARB specifically are recommended in CKD with proteinuria. But in the athletes, diuretic and beta blockers are almost banned. Alpha blocker can be used as a second-line drug. Rule out substance abuse in the athletes. Next. So treatment goal are general blood pressure target for children with the hypertension, that we should aim at the less to bring down blood pressure below the 130/80 or less than 98th percentile. For the adolescent, 13 years old are above. So we want to bring it down in below the 50th percentile mean arterial pressure. ABPM target with the CKD and hypertension, follow up every 4 to 6 weeks, and patient managed with the lifestyle alone can often be reviewed every 3 to 6 months if things are good. So this is a small poetry I have put for the control of blood pressure, and it converted into a poster. That is, if blood pressure crosses the 120/80 mark, take care, it is a ticking alarm clock. Start counting the calories in every meal. No more whites. Choose a rainbow deal. Daily jog or walk for an hour or more. Ration the salt as advised by your doc. Less sugar, less saturated fat. Meditation daily on a yoga track, and keep the waist to chest ratio to check. So
Now I think we will have
right.
to skip the
Okay.
questions because
Okay.
already 14 minutes are over. So
Okay.
now I will sum up it the lecture which you have given. So not every elevated blood pressure in an adolescent athlete represent primary hypertension. So performance anxiety, stimulant use, then overtraining and psychosocial stress can significantly alter blood pressure pattern. So ambulatory blood pressure monitoring is extremely valuable before labeling a young athlete hypertensive. So thank you, Mishra Madam, for joining and giving overview of pediatric hypertension. It was very nice interaction with you. So now
One thing I want to add, like for the potassium salt, one should be very careful whenever using, and you just see how we should go for it.
Yes. Now I request Dr. Anju Virmani Madam to start her the case presentation and take over as a faculty.
Thank you, Dr. Suchit. And I would like to start with expressing my extreme gratitude for this opportunity to be the one of the speakers at the first marriage of the two very important chapters. So let me start with Savita, a 15-year-old girl who presents with facial hair growth, acne, irregular menstrual cycles, weight gain, withdrawal from social activities, for example, school functions, due to body concern issues. She had her period at menarche at 11 years. Her periods are coming every 2 to 4 months, quite irregular with fair amount of menorrhagia. Physical activity is almost nil because she has 4 or 5 hours of screen time. Online homework itself takes 2 hours. Social media needs another 2 or 3 hours. She has to go for tuition. Dinner is at 10 o'clock because Papa comes home at that time. And bedtime is 12:30 to 1 a.m. Strong family history of diabetes, hypertension, mother and younger brother also obese. Now, a history which is often not taken, 6 people in the family, 6 liters of oil, 2 kilos of ghee per month, and about 2 to 2.5 liters of buffalo milk every day, something that the dietitians usually don't remember to ask. Junk food is almost daily because Dadi takes namkeen. Biscuits have to be there. She's fond of sugar-sweetened beverages, and she's become very fond of burgers and momos. This is a very characteristic history that you would get very often. And this young girl, already with a BMI of 33.6, has severe hirsutism, acne, acanthosis. You can see why she doesn't want to step out of the house. Her testosterone is borderline high. LH-FSH ratio is very significant in terms of PCOS kind of picture. Rock bottom D3, very common again. A1C, which is suggestive of prediabetes, dyslipidemia, normal 17 OHP, and the very concerned thyroidalgia with a TSH of 9. The ovaries are very characteristic. Right ovary 12 cc, 18 peripheral cysts, left ovary 11.5 cc, 19 cysts, stromal hyperplasia with moderate depression on screening. So you would say fine, PCOS, but what has changed, next slide please, is that PCOS itself has changed. And what used to be PCOS is now being called polyendocrine metabolic ovarian syndrome. The paper came out on the 12th of May in Lancet. And next slide, please, sir. And Dr. Helena Tive has explained very carefully why this name has been changed as a result of a multi-step global consensus process from PCOS to polyendocrine metabolic ovarian syndrome. The official name has been adopted to better reflect the multi-system nature of the syndrome rather than focusing only on the ovaries and the reproductive aspects. The polyendocrine reflects the broad hormonal imbalances, not just the androgen excess. The metabolic reflects the issues including insulin resistance, weight, and cardiovascular risks. And of course, the ovarian, which keeps the ovarian aspect alive without implying that the ovarian cysts are central or even a universal component. Next slide, please. If you were to look at adults following exclusion of other disorders, PCOS was diagnosed in adults if 2 of the 3 criteria were met. There had to be oligoanovulation, clinical or biochemical hyperandrogenism, and polycystic disease on ultrasound or elevated AMH. And as we all know, this was primarily perceived as a gynecological or an ovarian disorder. But increasingly, as the underpinning by the endocrine disturbances in insulin, androgen, and the neuroendocrine and ovarian hormones was recognized, it was recognized that this is multi-system health impacts, a growing health and economic burden. Next slide, please. This whole thing was changed. And as I said, the features can be enormously metabolic. BMI is generally high in PCOS, with the obesity contributing to its severity. But in the Indian context, the weight gain is already very sinister. Dr. Nirmala has talked about topi, the thin fat Indian that Dr. Yajnik is very fond of talking about, that for the same weight, we have much more central obesity and have a higher fat to lean mass ratio. There is often dysglycemia, GDM or frank type 2 diabetes. This girl has pre-diabetes, hypertension, and later pregnancy-induced hypertension is not unusual. Dyslipidemia like this girl has. Metabolic dysfunction related associated steatotic liver disease, MASLD, which was earlier called NAFLD, cardiovascular disease, sleep apnea, which was there in Dr. Jugesh's case also, and of course the ovulatory disturbances, the irregular menses, the later infertility pregnancy complications. And with all of this intertwining, the psychological factors including depression, anxiety, poor quality of life, eating disorders, and the dermatological consequences, which for an adolescent girl can be absolutely devastating. Next slide, please. The problem for us is that in adolescence, we need a lot more caution. The criteria are all based on adult disease, and we have to factor in not just the now, but the long-term risk factors. We have to keep psychological factors in mind, and we have to keep in mind that normal puberty can mimic PCOS and have an overlap with PCOS or PMOS with a very high risk of over and underdiagnosis. For example, acne, very common in adolescents. Menstrual irregularities, at least for 1 to 3 years post-menarche, is par for the course. There is physiological insulin resistance that Dr. Nirmala has already talked about. Ovaries are naturally large and polycystic, very commonly. And then, of course, the fact that hirsutism takes time to manifest fully, and that the Feynman-Gallwey score is much less useful in adolescents. Then, if we move to the lab, in adults, hirsutism, alopecia, and acne can be a very good surrogate marker for diagnosing hyperandrogenism. But as I said, in adolescents, acne is already very common and it's often reversible. Alopecia is very uncommon. And so hirsutism is the substitute for biochemical hyperandrogenism. Next slide, please. And then, of course, the lab gives us even more trouble because the limited sensitivity of the testosterone assays in the ranges applicable to young girls means that you're not very sure what you're doing when you're looking at testosterone. There are no clearly established normal ranges. Other androgens don't help. On top of that, the ultrasound can be much more dicey because the transvaginal ultrasound is obviously not possible. The abdominal ultrasound, not so accurate, not so useful in girls less than 17. And one of the things that has changed is that the old 12 follicle story has been given a bypass, and at least 25 follicles are required. Of course, we do have to exclude other endocrine causes like late onset CAH by doing a 17-hydroxyprogesterone, which in this girl was quite normal. Hypothyroidism. Now, here we have to remember that the TSH of 9 did not represent hypothyroidism. Usko thyroid nahi aa gaya tha, right? Because TSH up to 10 is quite common in obesity, and so she doesn't really require any treatment, just reassurance on that aspect at least. Next slide, please.
What
So how do we work up? Yes,
Yeah.
sir, absolutely. So the theory part is all very well, but what do I do with this girl who's sitting across the table? I need to look at her weight and her BMI, her waist circumference, her blood pressure. Blood pressure, as Dr. Smith has already pointed out, is often either ignored or taken very wrongly. I must look at account for her acanthosis. I did order an ultrasound, and you could see what the reports were very characteristic of PMOS. The LH-FSH ratio on the second or the third day of the cycle is very characteristic in that the LH predominates and the ratio is more than 2:1. The other conditions were ruled out. She clearly had dyslipidemia, which fits in with the metabolic part, which is what the recurring theme has been so far in the webinar. A1C can be very misleading. HOMA-IR, we have to remember, is not for the individual. And very often, if you don't have a random high sugar, you may need to do an OGTT with 75 grams of glucose. The caveats, of course, are, if I can just go back for a second, Dr. Tamuli, TSH more than 10, I would like to caution you again, can be simply there in simple obesity. A borderline prolactin is not unusual because a child could be anxious. It's a stress hormone. Basal cortisol is often high in simple obesity, so we often would prefer not to do a simple cortisol in the morning, but an overnight DEXA suppression test. And as I said, A1C can be very misleading. Serum insulin levels, which the dermatologists absolutely adore, are usually unhelpful and should be judged only with the corresponding blood sugar, and HOMA-IR doesn't really help. Next slide, please.
Yeah. Your 10 minutes are over.
Okay, sir. I'll just take the 1 or 2 minutes more that I'm allowed, and point out that the psychological aspects are very important, particularly in adolescents, because they may have a number of problems, and that the mental stress correlates with the compliance. If the child is stressed out, she's not going to adhere so much to the advice that we give her. Next slide, please. So the comprehensive management strategy would tackle compliance issues, but what has been already emphasized, it has to be family centered. We can't say iska khana, iska dhyan rakho, isko aam mat khilao. The nutrition and exercise counseling has to be across the family, including weight reduction strategies. Menstrual regulation is very important. Psychosocial counseling is very important after a screening, reduction of unhealthy social media influences, but emphasizing what matters to them. If I tell her diabetes will make a problem with infertility later, it's not going to be a problem. But she will look better. She will feel better. She will study better. Next slide, please. Insofar as the menstrual regulation is concerned, oral contraceptives are very effective with irregular periods. They reduce the androgen levels, improve the acne and the hirsutism. And they work very well if combined with anti-androgens, of which the most popular is spironolactone. Metformin works beautifully in these girls. Low dose may work very well with a non-obese girl, but here with a high BMI, metformin will work beautifully. Pioglitazone is something which is making a comeback and can help enormously because it's an insulin sensitizer. We may have to add a statin, but not in the first go after 5 or 6 months. Make sure that she doesn't get pregnant because the girl may be sexually active. Vitamin D is often low and has been emphasized earlier by Dr. Nirmala and by Dr. Smita. The importance of supplementing iron and B12 is very high. And I would like to point out that though the weight loss drugs are absolutely sweeping the market and Novo had a higher profit ratio than the GDP of Denmark, they have a lot of problems. And as Dr. Jugesh cautioned us about bariatric surgery, I would caution you about these drugs. Very simple to get into that mess, very difficult to get out of it. Next slide, please.
Oh, thank you very much, madam, for your excellent presentation. And PMOS or PCOS in adolescents is both a metabolic and psychosocial disorder. So treating only menstrual irregularity without addressing obesity, emotional health, and body image issues leads to incomplete care.
That's
And
right.
early adolescent PMOS clinic should incorporate mental health screening and proactive handling of the issues. So I think this should be summarize your case. And thank you very much for joining.
Thank you, sir.
Now I request Dr. Chitra Dinakar madam to start her case. Chitra madam, please.
Thank you, Suchit. I'll try to minimize overlap and focus on areas not covered by my co-speakers. We have Sunil, a 14-year-old, who's come for a viral URI, which is a commonest presentation many times. And as you can see, his weight, BMI are off the centile mark, but that's not what the parents have come for. Clinically, he also has acanthosis nigricans. He has all the risk factors in the family, with both parents having all the listed conditions here. And even his routine BP monitoring shows what's in orange is elevated and what's in red is actually stage 1 hypertension. So you have a routine clinic follow-up revealing all of these. And most of the time, we are left with cajoling parents for baseline investigations after counseling, of course, on future risks. But we, at the same time, have to be very careful about what terms we use in Sunil's presence. We should never be using terms like overweight, obesity, and these are all stigmatizing, fatty. These are all very stigmatizing and will puncture his self-esteem terribly. I'm sure he's already aware of the problem, but it's very important we don't use these terms. So we have commonly this setting, and we do have a need for further biochemical investigations as screening, since we have these parameters of high BMI. So what would be useful? Next slide, please.
Yeah.
We have a app which is very useful, I think, at least for the minimum parameters we're looking here. IAP growth charts, that's how it's looked. It's free, iOS, Android enabled. And you have in that, the next slide, we have just to put in the age of the child, the gender, male, female, and put the weight and height, and you get the graphs generated when you click. So here his weight is on the 90th centile, his height is on the 50th centile. This or above 50th itself will rule out most endocrine conditions, so you don't need investigations, secondary causes. And you have the BMI here. You have two lines, 75th and 90th are our Indian corresponding lines for adult, 23 BMI and 27 BMI, corresponding to overweight and risk for obesity. So this is a useful and very easy chart that you can use. Very importantly, and not used by us routinely, is the waist circumference chart, again brought out by the IAP. And you will see here, anything more than the 70th centile itself in our Indian genetic risk population is considered high, not the 85th as in the Western population. So anything more than the 70th centile, so even as low as 85 in this age, would be considered significant. So please start using the waist, and that's the single most important criteria for looking at truncal obesity.
So can you explain a little more about counseling this adolescent and family?
Yes, right, Suchit. So what we would talk about is, we know and we can anticipate that this child will already have body image issues. So it's important to understand by talking to him what his views are when he sees his body. So what does he perceive? How does he see himself? And please let him talk about what he thinks he is. Some adolescents will pretend they feel they're normal. Some will say, I feel very fat. How does he feel about his body? Okay, that's okay. I understand. What do you feel? So he may come out to saying, I'm unhappy. I feel extremely sad. I feel ashamed. I'm disgusted. I hate my body. Okay, so these are terms that they come out with if you give them a chance to talk about what they feel about their body. And words we can use is, yes, I understand it must be very difficult. I'm really but happy that you're able to share these feelings with me. Let us focus on trying to help you feel better, not lose weight or get thinner or become better. So your weight, size, or shape doesn't define who you are. You are a person who's sharing, who's caring, who's so loved. So those are the things to be proud of, not necessarily something they've achieved in their marks or in their sports. And in order to improve your health, strength, and confidence, not reduce weight, are you okay to work on some changes in your habits, which are within your power, and let's work on it together with your family. So here we are partnering with him and his family and also taking his permission in a way. And also we're looking at in 3 to 6 months time, things should be better for you. You should be feeling better about both how you see yourself as well as how you feel about it. And that gives us a time frame also to work on with the family. So investigation biochemically is indicated, so we could cajole them and get some baseline labs. And you can see here, what I'll highlight is only what's in the yellow and what's in the red maybe, because that will tell us that the LDL cutoff for him, for his age. Please look at norms because we can't remember all these values for acceptable, borderline, and high. And we understand that even borderline becomes important if you have other comorbidities, and high sometimes is dangerous and you may need even drug therapy. So in general, LDL cutoffs is 110. HDL for adolescents should be more than 45. So this is an issue already. Triglycerides is way off here. And ALT, though you have norms of 35 and ALT is only marginally elevated here, in child and adolescent, what is suggested is anything more than 30 could be significant, especially if it is a screening test for mass LD. So we have to remember norms of more than 30 could be significant, but there are other causes for elevation. So please repeat it. If it persists to be high even after a repeat within 3 months or at 3 months, then it is significant. Next slide, please.
So can you clarify the significance of ALT elevation? And does he have fatty liver disease or NAFLD, that is non-alcoholic fatty liver disease?
Yeah, thanks, Sujit. Yeah, that's an important question. How do you interpret this ALT? Next slide.
Yeah.
So importance of your high ALT could be due to mass LD. That is metabolic dysfunction associated steatotic liver disease. That's a new term. Earlier, non-alcoholic fatty liver disease was used. That's no more used right from 2023. In fact, non-alcoholic implies an exclusionary term. Fatty is stigmatizing. So now we stick to what is pathologically a problem in the liver, metabolic dysfunction, steatotic liver disease. And usually in children, adolescents, it's associated with just waist circumference being more. That's a clinical clue to visceral adiposis with or without insulin resistance. And that can be acanthosis nigricans, may or may not be biochemical necessarily. And very important also is to look at other causes for raised ALT in children. Drugs like valparin and your steroids, genetics. If you have a family history of hypertriglyceridemia, autoimmune hepatitis C, HIV, hypothyroidism, IEMs also with metabolic dysfunction. So generally, we are familiar with how to rule out other conditions clinically by history and examination, but we have to always make sure the ALT elevation is not due to any of these other causes. And apart from MASLD itself is not very descriptive. You have subcomponents in that, hepatic steatosis, where you have only fatty liver, where you have MASH, that is steatohepatitis, where there's an inflammatory component, MET-ALD, where there is associated alcohol and metabolic dysfunction, liver fibrosis and cirrhosis as a component of MASH LD. And of course, finally, liver cell failure. But we have to remember that fibrosis, cirrhosis, liver failure are all happening over decades, usually in the middle age and in the older age group. About 20-year follow-ups have shown about 10% to 15% going there. Next slide, please. So basically, to summarize, we have a normal liver, then we have steatosis converting to hepatitis, and then the fibrosis. So next slide. Histopath usually shows us this macrovesicular steatosis or fat accumulation within the hepatocytes. It can also show us just ballooning of the hepatocytes, fibrosis, either perisinusoidal or periportal, and all of these are progressive damages that are happening in the higher grades of steatohepatitis. Next slide, please.
How can we confirm the diagnosis of MASLD?
Right. So this again is a little of a difficult question. How we can screen, I will tell you. When we have a base circumference which is high, do an LFT. An elevated ALT is a good screening tool. And in fact, ultrasound is not recommended as a routine screening tool because it can only detect moderate and severe degrees of hepatitis or fatty steatosis. So what is recommended is just do an ALT or a full LFT if you want, because sometimes gamma GT also can be elevated. Any level of elevation is significant. More than 30, like I mentioned, is the cutoff. Now, if you have a fibroscan, instead of the ultrasound, you can even opt for fibroscan because it has the advantage of showing not just steatosis, which is graded 0 to 3, but can also show the degree of fibrosis graded 0 to 4. So this may be a useful thing, especially for follow-ups. Now, you don't routinely need MRI or biopsy because confirmatory biopsies are invasive. You would not necessarily do that. So for us, in summary, you will do an ALT and maybe an ultrasound if you want to screen and also confirm steatosis first.
Yeah. So what is the treatment for MASLD?
Yes. So in adults, you have a gamut of drugs also, which are used specifically for MASLD. But next slide, Sujit. What I would concentrate on is giving, next slide. Our adolescent had grade 2 steatosis on ultrasound. No pharmacotherapy specifically for liver disease, irrespective of the grade of steatosis or fibrosis in children and adolescents. So basically, there is no targeted treatment for MASLD in adolescents as of now. In adults, you do have some drugs. Vitamin E has been used, and some cysteamine has been used, and there are some other thyroid receptor agonists which have been used, but not in children. So what are the treatments specified in children? Of course, lifestyle measures, which I may just glance over in the next few slides. Vaccinations which are hepatoprotective, if they've not already received them, hepatitis A, definitely specific counseling or not to even try or touch alcohol because that's going to aggravate the problem. GLP-1, there is no role here unless they are indicated for weight or even your insulin resistance in subgroup of adolescents. And vitamin D levels, definitely. These are all recommended in our child. And what's in blue is what is specifically recommended for Sunil. And follow-up of MASLD is definitely good. If you have good interventions for lifestyle measures, there can be a reversal of steatosis, but no reversal of fibrosis.
So, what now next? What are the lifestyle measures for weight reduction? Hello.
So yeah, counseling, basically counseling. What's known to work is behavioral change counseling. So there's no evidence to show motivational interviewing or other methods help. What there is evidence is behavioral change counseling as of now. Goal directed. So parents again need to be counseled because they are role models, and we need to include the family in the lifestyle changes that we are proposing to do. And meal plan. So in a meal plan, we look at I give a caloric restriction depending on the severity of say 15%. Protein is not restricted. We have to promote protein. We talk of the 8 food groups as per the ICMR daily food plate. Physical activity, a lot of us may not be aware, we need 3 hours of movement through the day, out of which 1 hour is vigorous activity. So this is for normal adolescents. Forget about obesity and overweight. So this is something we have to educate ourselves with. They have to move, not sit. And media use, less than 30 minutes of entertainment media use. When we talk of 2 hours, we are not talking about entertainment for 2 hours. We're talking of using it for educational purpose or creative purpose. But media use for entertainment, less than 30 minutes. And sleep, many again are not aware that adolescents need 8 to 9 hours of sleep. And very sadly, we need a lot of standardized research operational for optimizing management as well as to look at benefits of whatever interventions we are doing. We don't have standardized modules, especially clinic or hospital based. So one of the plates, ICMR plates, you can see here, the food groups, half the plate over the day. This is a day plate. So half of it is veggies, out of which 100 grams or so are tubers, and fruits again constitute about 100 grams. So you have a big proportion chart here where you're talking of roughly 250 grams of cereals, about 85 grams of legumes, only 85 gram plus of legumes, meat around the same 100 grams maybe, and milk at least 300 ml, and you have veggies and fruits of 400 grams. Fruits 100 grams. So literally half a kg of fruits and vegetables. Sujit, just the previous slide, please, because there's a tip there which is very useful. So if I may need to advise a family, I would look at telling them that basically less than 5 grams salt per day, less than 20 ml oil per day, less than 20 gram sugar, or 4 spoons of sugar, 4 spoons of oil per day. This is per person per day. So if you have a family of 4, you calculate what you need for the month, purchase that only for the month or store it only for the month, and don't have an overuse. Eating out only once weekly, and oils include all oils, including ghee, butter, paneer, cream. So don't assume that fats are only oils. Avoid any packaged food, irrespective of whether they say it's healthy or with milk or with no trans fats, because all of them are labeling only for advertisements, and we don't need packaged foods. So this could be a tip. And also proportions have to be spoken about. And protein should not be restricted. Calories and white foods have to be restricted.
So 1 minute is remaining.
Yeah. So excessive screen time, they always talk about no time for physical activity. So take the time from the screen is what I recommend. And this is again educative, handouts which tell you how much sleep you need. Next slide. Next slide. And these are again the previous one, educative handouts meant for parenting guidelines from the IAP, which is again specifying the types of physical activity that you need. Activity that is not necessarily in the gym, but maybe in a park. You have a lot of equipment there also. You have running, playing, just free playing is also a good activity for children, including structured sports for an hour. So these can be given as handouts because they define a lot of timings and benefits of physical activity. Physical activity itself has mental health benefits, including treatment for depression, equal as antidepressants, especially in the recent meta-analysis. Next slide.
Thank you, madam, for very excellent presentation. So what are the take-home messages? Do LFTs in adolescent with overweight or obesity? If ALT is elevated, liver fibroscan or ultrasound for baseline score for steatosis or fibrosis is essential. Then MRI and liver biopsy in selected cases like severe or progressive cases. And treatment directed to lifestyle, metabolic abnormalities, insulin resistance, or lipid and hypertension, and liver protection like vaccine and vitamin D, as well as no alcohol. So no drugs approved specifically for MASLD in child or adolescent. Counsel and motivate for lifestyle measures that can reverse pathological steatosis before fibrosis develops. Use adolescent-friendly approach. Focus on self-esteem and avoid stigma. So partner with family as well as adolescent. And I think in this topic, Chitra madam has given excellent overview about counseling, which is very, very important. And that counseling, if you do it properly in your OPD practice, I think that helps a lot. And thank you very much for the patient listening. And I think we have finished in time. So thanks all faculties for being in time. Thank you very much.
Thank you.
Thank you to you for this, actually, managing the time.
It was fantastic, just fantastic. And beyond imagination, all the faculties, superb. All the
Madam, your voice is breaking.
That was really amazing. Just amazing. Thank you so much. Swati, we can take up a few questions.
Yes.
There are, some questions were there and they have been already answered by the faculty on the chat. There are many comments appreciating and thanking our faculty. There is one suggestion that there are no counselors or dietitians in the schools. The AHA and our chapter should take it ahead and the policy making and make it compulsory for the schools to arrange the counselors and the and other paramedic staffs there. Requesting AHA leadership to flag these issues and make it compulsory. So that was there.
Swati, one please. Dr. Sivaprakash sir,
Hello.
there was too much of noise. Yeah. Please start. Please.
So, madam, there is
Continue, Swati.
Yes, there was a suggestion by Dr. Umesh sir that in urban schools, irrespective of the guidelines, there are no certified nutritionist or medical team for checkup or for an emergency. A psychologist or a counselor is also not there. So he has requested AHA leadership to flag these issues and make these compulsory for adolescent health. And anthropometric screening using.
Yeah. Any questions? We are more focused on question rather than other suggestions. Yeah, please. Please.
Yes.
Honestly, ma'am, if we can have 2 or 3 major changes in our approach, one is that if all the boys and the girls are given cooking classes in school, the other is if the AHA can be involved in monitoring the canteens, if they're going to serve samosas and pakoras, if they won't get much joy. If they're given sprouts and peanuts, they will. And if the AHA or the pediatricians in general can talk about attitudes with the teachers, and that would go a very long way.
That's true, ma'am. Actually, as you very rightly pointed out, all the pediatricians, right? We have to do something, and we had initiated a adolescent-friendly school initiative and child-friendly school initiative, and that was a very successful movement, ma'am. All over India, we had done, and IAP played a great role there, and we are still doing it. Some of the cities still going on. So that was a successful moment, and I think. That had affected a lot. I mean, we could get good results, especially the canteen food क्या मिलना चाहिए, है ना? Adolescent friendly toilets होने चाहिए, ये वाला सब कुछ,
And madam,
Madam,
SSS from
can I? Hello. Madam, during this now CBSE and Government of India. CBSE and Government of India has issued
Madam, there are no academic questions here.
No academic questions, then I think we will take the comments and other stuff in our delegate group, which we have already created. Group will for 2 more days, and the faculties are there to answer your questions. So please post your questions and suggestions in those groups. And please join that group if you have not yet joined. I think, am I audible, Swati?
Yes, ma'am. Yes.
There is one question by Dr. Chitra Kulkarni. Will ultrasound elastography gives early diagnosis of NFLD?
Yeah, maybe I can take that. So ultrasound actually only tells you steatosis. It doesn't tell you fibrosis. Okay. So fibrosis, you need to do a fibroscan, which is actually an ultrasound of the liver using some kind of pulse waves, which look at the shear force over the liver. And depending on the speed of how the waves bounce off, you can decide whether there is a grade 1 to 4 fibrosis. So I think fibroscan is the useful test if you're looking at fibrosis. Ultrasound only tells you there is fatty. And if you find the grades are higher, maybe grade 3 or 4, you can go for a fibroscan. That may give you the degree of fibrosis rather than just looking at an ultrasound.
So, Dr. Chitra, this ultrasound is very useful as a screening device. Fibroscans are not that
so, ma'am, I was surprised. That's what I thought too. But when I looked at the recent updates on screening use of ultrasound, they said it's not a good screening tool because it's supposed to be better for moderate severe steatosis. And in fact, they have done studies to look at ALT as the ideal screening method, at least in
Dr. Chitra, the point is, if it is normal in the ultrasound, you can't say that there's no fatty changes. But if there are fatty changes, it's a very useful, very cheap, very bedside kind of screening test. So you can't dismiss it as a screening test. Fibroscans are not easily available and they're expensive.
Yeah. So I'm not dismissing, ma'am. Basically, evidence suggests using ALT. So, in our setup, you can use it. as a choice. But what is evidence-based? I'm just sharing, that's all. So ALT is recommended. Ultrasound has been demoted to not a screening tool, because meaning I don't know whether we should be using screening ultrasound, because there are other causes also in our country. A lot of infections cause slight elevations in ALT, and maybe there are some documented genetic metabolic causes for raised fat. In fact, that recent paper I shared also on our group was on 30% have some liver fat. So does that translate to mass LD? I don't know. So we don't know a lot of these things, and using something as a screening tool usually is better when you know what to do next. So when you don't know how to interpret the result and where you're going to end up with using that tool, I may be a little careful. So if you have any ALT elevation, I've reduced the cutoff, right, to more than 30. Then maybe in a setting where you have clinical waist circumference being above cutoff, it would be useful. So these are really not diagnostic. They just tell you there's fat in the liver, and there are many causes of fat in the liver. And our thin fat phenotype may actually, we may be surprised if you use ultrasound in just some routine school-going children, which is what has been the paper which I just shared today in the group. So that's our problem with using it as a screening tool. But in a clinic setup with a particular patient, definitely with risk for obesity, you can use ultrasound and ALT and LFT and everything.
Thank you, madam. Thank you for that answer.
I think so.
Ma'am,
If there is no question,
this is one suggestion by Dr.
conclude
that AHA should take up the matter of physical games in schools.
Absolutely,
Yeah,
ma'am.
sure.
I completely agree.
AHA has a lot to do.
Physical activity has multiple benefits, ma'am. So it's worth investing in it. All mental health conditions will benefit. NCDs will benefit. Your general camaraderie and socializing also will benefit. And really, it's something that is under.
Most schools give only 1 period per week, ma'am, for physical.
Yeah, and another thing I've noticed is tuition sometimes is used as an excuse.
Now it is already 10 minutes over.
Yeah.
We can carry on with the discussion on the group. Please.
Thank you.
Toxic coaching culture. Coaching culture, we have to stop.
Yeah, please. So, Dr. Invite Dr. Shami. I invite Dr. Shami to please sum up. Dr. Shami.
Dr. Shamik, you're muted.
Thank you, Dr. Sushma Desai, and all our esteemed panelists. It started off with a wonderful discourse by Dr. Nirmala, and gradually we moved on to be touched upon different types of NCDs by Dr. Chetwal, Dr. Anju Virmani. We had also a wonderful case presentation by Dr. Smita Mishra, and I think it was all rounded off well by Dr. Chitra Dinakar. It was good to have the interaction. I'm sure there have been quite a few take-home messages today, and we look forward to continued interactions. This is a request to everyone. I think so. About 124 people have actually signed up the Google form and registered themselves for this particular webinar series. I request every one of you, you've been sent on your email the WhatsApp link to join the WhatsApp group and contribute meaningfully to the WhatsApp group, because this is your opportunity to put forth your views as well as learn from your esteemed colleagues. So my honest request to all of you who have joined in to make the best use of this platform. Thanking each and every one of the participants, especially Dr. Suchit Tamboli, who has been working overtime, burning the midnight oil, and literally, putting this whole show on, which has kept us all engrossed over the last more than 1.5 hours. Thank you so much, sir, for your very earnest efforts. And I hereby take the opportunity of thanking all the attendants who have so patiently sat through this whole discourse. A very good night to all of you, and hope to see you soon with another edition of the Interchapter webinar. Thank you so much.
Yes, sir. Thank you very much.
on the 17th
Thank
of
you.
June. That's on the 17th of the June. And
Yes,
yeah. So thank you so much, Dr. Nirmala ji, Dr. Jugesh ma'am, Dr. Anju ma'am, Dr. Smita ma'am, Dr. Chitra, and above all, my dear friend, Dr. Sutta Moli, for being with us today, having really meaningful discussion and the amazingly covered topics.
ma'am, we've lost your voice. Okay. With due apologies, I'm ending the
The
talk.
internet is good. Let us complete the things. Thank you.
Thank
Thank you.